Hi, this is Dr. Nick with the ECG Academy, and we're going to finish up our discussion on atrial flutter. And this chapter is about flutter that has an unusual appearance, flutter that looks deceptive and makes you think about something else. Here's a picture of a chameleon that kind of blends into its surroundings. And think of those flutter waves as kind of blending in and looking like something else. So let's get right to it. Now, here's a 12 lead that I really enjoy showing people. When you look at the forest here on the rhythm strip, you see that it looks quite regular. The QRS happens to be a little bit wide, if anybody noticed. It's about 150, 160 milliseconds in duration, so there's definitely an interventricular conduction disturbance. And when you look for P waves in front of the QRS complex, you see what looks like a pretty nice-looking P wave with an isoelectric segment following it. And it seems to be in most of the leads. You're looking at P waves. And if you measure this PR interval here, it's a little bit long, about 280 or 300 milliseconds or so. And people would be very tempted to call this normal sinus rhythm with a first degree AV block and an underlying IVCD, maybe a left bundle branch block. But if you call it that, you'd be wrong, because it turns out that this is not sinus rhythm. And the clue is to look at the forest, but then start looking at trees and make sure you look at every single lead to make sure you know what the rhythm is. And here's the clue, is in V1, you have very large, very prominent flutter waves that are marching through. And unless you looked at V1 and specifically analyzed the atrial activity, you'd miss them. You can see them a little bit in V2, but they're much, much smaller. But these big, giant flutter waves are marching on through. If you measure two flutter waves, you get a rate of about 100, and so the atrial rate here is around 200 beats per minute, which it turns out that the patient's on an antiarrhythmic drug and their flutter rate has slowed down somewhat. If you look at some of the leads, you actually get a sense that there is a sinusoidal pattern. It looks like a sinus wave, and you see those flutter waves very, very subtly, but only in certain leads. So it only looks like a sawtooth pattern in some leads. And that's why I would call this a slow atrial flutter rather than a rapid atrial tachycardia. Because atrial tachycardia, I prefer seeing discrete P waves at a rapid rate with a fairly long isoelectric interval in between them. At this rate of 200 beats per minute, it's really on the border, and it's only the appearance of this sort of sawtooth pattern in some of the leads that would make me call this a slow atrial flutter with 3-to-1 conduction, because you have 1, 2, 3 flutter waves, the one superimposed on this QRS complex, corresponding with this QRS, and then you have 1, 2, 3 again. So this is really a slow atrial flutter with 3-to-1 conduction. The word slow in this case I'm using to denote that the atrial flutter rate is only 200 beats per minute, which is a little bit slow to be flutter, but we can see this when a patient's on a drug, and let's say that you have the atrial flutter that's going round and round in a circle, but under the effect of this antiarrhythmic drug, that electrical signal is slowed down to the point where the rate falls below 225. So this is kind of an unusual appearance, but it's flutter nonetheless, and that's why it will fool a lot of people into thinking that this is just normal sinus rhythm with a first-degree AV block. That's clearly not what it is. So make sure you always look at V1 to look for P waves, because you'll frequently see an atrial rate that's faster than what you initially measured. Okay, let's go on to the next one. Now in this 12-lead ECG, if you scan the forest, you see that the QRS complexes are irregular. And there does not seem to be any specific pattern. Some of these complexes are fairly fast, about 100 beats per minute, and this one's a little bit faster, about 120. And then you have a little break in the action. It slows down briefly, and then it speeds up, and then it slows down again towards the end. So there's no pattern to it. It seems to be irregularly irregular, and that makes you think that there's some kind of atrial arrhythmia going on. When you look at the QRS complexes and look for P waves in front of them, there do seem to be discrete P waves in front of some of the QRS complexes, but not everyone. This one does not look like the same P wave. This one looks like sort of in between, and some people would be tempted to start thinking about multifocal atrial tachycardia. You see this one seems to be upright, and then there's one here that may be inverted. But the key here is to look at the long intervals, because that's where you'll see more atrial activity, because there's no QRS complexes to get in the way. And immediately I see that there are 2 bumps in a row. And even if you look at AVR, there's 2 negative bumps. And when you look at the rhythm strip here in lead 2, you see 2 bumps in a row. That basically establishes the atrial rate. The atrial rate here is about 250 beats per minute. Now, do we have very pretty sawtooth flutter waves? The answer is no. What we have are very short, discrete flutter waves with a long isoelectric interval in between them, so it looks more like this. It's flutter nonetheless because the atrial rate is 250 beats per minute. In some areas you have 2-to-1 conduction, but towards the end it looks more like 4 or 5-to-1. But this is a kind of an atypical appearance to atrial flutter, and in fact we call this atypical atrial flutter. It's one of the types of flutter that you can recognize on a 12 lead, and we'll cover the different types of flutter in the advanced course. Just be able to recognize that you have an atrial rate of 250, and the fact that it looks like you have P waves in front of some of the beats is just coincidental. It happens when a flutter wave just happens to land in front of a QRS complex and gives the appearance that it's a P wave. But in fact, the atrial rate is much faster because the other flutter waves are buried here on the T wave, and this one's buried on the QRS complex, and then you have one, and then it's buried in the ST segment, and so forth. So it's a sneaky kind of flutter that resembles something else, but you need to be able to recognize it in order to make the right diagnosis. Okay, we'll take one last example. And I think this is a little bit easier to recognize. When you start looking at the forest, you see there are some narrow complexes, there are some wide complexes. The narrow ones are kind of sort of regular, but not exactly. Sometimes the R-to-R intervals are a little bit longer. Sometimes they're shorter. Then there's these wide beats. So this is a bit more of a complex tracing than you've seen in other examples. When you start to look for atrial activity, and you'd say, oh, I know, Dr. Nick said look in V1. You really don't see anything that looks like a nice P wave. In fact, this, which you think is a P wave, is actually the T wave from the previous beat, as is this. And you don't see that here because the PVC throws a T wave off, but this is the T from this beat. So these are not P waves, they're T waves. And in V1 and V2, you really don't see any kind of atrial activity that you can hang your hat on. But again, you have to use your imagination. You have to look for patterns in the underlying baseline. Essentially, ignore the QRS complexes and try to see what's happening underneath them. If you do that, you'll be able to see these little bumps in lead 1, and you'll be able to see this kind of a sinusoidal pattern. It looks like a sine wave. What do I mean by sinusoidal? Mathematical sine wave is something that you learn in physics, and it looks kind of like this, where it's spending an equal amount of time above and below the baseline. And so it kind of looks like a sine wave. That's why I use the word sinusoidal. It's not a true sine wave in the mathematical sense, but doesn't look as sawtoothy as some of the other examples that I showed you. Probably the only one that looks like a sawtooth here is an AVF. So this is atrial flutter with variable conduction. And then what are these wide complex beats? Well, they're ventricular premature beats, or PVCs, whatever you want to call them. There's 2 of them here. And so the diagnosis here is atrial flutter. Why? Because the atrial rate is, if you measure the rate here, take this flutter wave, measure 2 flutter waves over, and you get 300, 150, 100. That's got to be about 115, so it's about 230. So the atrial rate's about 230 beats per minute. You have variable conduction and frequent ventricular premature beats, and that would be the rhythm of this 12 lead. When you get to the intermediate course, we start to analyze the details of the QRS complexes and looking for other things like ST and T wave abnormalities. But for this basic level course, what we're concentrating mainly is the rhythm, because that turns out to be the most complicated part of the ECG. So even though I call this a basic level, in fact, you're getting some very complex physiologic lessons and insights into reading rhythm strips, information that you won't get in any other course on the internet. And I'm very glad that you subscribe to the ECG Academy. That's why I'm doing my best to turn you into an ECG expert. In the next section, we're going to cover atrial fibrillation, which is a very common arrhythmia. And the last section in this basic course deals with ventricular tachyarrhythmias. Well, until then, this is Dr. Nick with the ECG Academy. Thanks for watching.